Hello everybody. Today we are going to discuss about the hemolytic uremic syndrome. The term thrombotic microangiopathy refers to the group of disease characterized by the endothelial dysfunction and the formation of the platelet and the fibrin-rich thrombi in the small blood vessel. As a thrombus forms, there is consumption of the platelet and mechanical disruption of the erythrocyte, which leads to the typical hematological manifestation of thrombotic microangiopathy, thrombocytopenia, and microangiopathic hemolytic anemia. That is schistocyte fragment formation, raised LDH, and the reduced hepatocyte. So previously, the thrombotic microangiopathy were classified according to their clinical presentation with neurological symptom predominating in thrombotic thrombocytopenic purpura and acute kidney injury in HOS. However, there is significant overlap in the clinical features of TTP and HOS, and the disease are now classified based on the etiology. So the TTP is caused by inherited or acquired defect in Adams 13 activity, which is a circulating protease responsible for the degradation of ultra-large 1 Wilbrand factor multiple. In the absence of this Adams TS13, these multimer accumulate on the surface of endothelial cell, leading to the formation of platelet-rich thrombi. The classification of the HOS is more complex as a pattern of clinical disease consistent with the HOS can occur in the wide range of clinical scenarios. Most cases, that is 90% of cases, occurs following infection with the Shiga toxin producing bacteria, either enterohemorrhagic E. coli or Shigella dysentery, and typically affects the children. The remaining 10% have the traditionally been grouped together as a atypical HOS. Now, HOS associated with the infection. Infections are the most common cause of HOS. In addition, infection, for example, influenza, may act indirectly as a trigger for development of thrombotic microangiopathy in patients with the genetic predisposition to the disease. Now, Shiga toxin-induced HOS. HOS associated with infection with the Shiga toxin producing bacteria is one of the commonest cause of AKI in children but can occur at any age. In Europe and North America, E. coli 0157 is the serotype most commonly associated with HOS. However, this appears to be changing with fewer cases of 0157 associated HOS and increasing number of cases due to other serotype reported in some countries. In part of Asia, Shigella dysentery type 1 Now about clinical feature, abdominal pain, diarrhea, and vomiting typically occurs 3 days after ingestion of the bacteria. Approximately 10% of the patient exposed to the bacteria will develop HOS. The development of the HOS is influenced by both pathogen and host-related factors. In 5 to 10% of patients with the stake HOS, there will be no preceding history of diarrhea, highlighting the importance of microbiological investigation of all patients with thrombotic microangiopathy, irrespective of history. Renal involvement is present in most cases and dialysis is required in 50%. Renal recovery after 1 to 2 weeks is usual and end-stage renal disease after initial presentation is uncommon. Neurological involvement is the most frequently reported extrarenal manifestation, with seizure and reduced consciousness level reported in up to 1/3 of cases. Other sites that can be affected include intestinal tract, pancreas, eyes, and heart. The mortality rate in the acute phase of disease is approximately 2 to 5% in HOS, Shigella toxic HOS, but higher when HOS followed Shigella infection. Long-term renal sequelae are common with hypertension and the CKD occurring in 25 to 40% of cases. The Shiga toxin producing E. coli can colonize the intestine of healthy animal and can enter the food chain if infected meal or other food products are consumed. Pathogenic E. coli closely associated with gastrointestinal mucosa and toxin translocates through epithelium into circulation, where it binds to circulating erythrocyte and leukocyte. The toxin, which comprises one unit and 5V subunit, binds to tricylceramide, that is GB3, on the surface of target cell. It is taken up by the endocytosis and then retrogradely transported to endoplasmic reticulum. The A subunit inhibits the protein synthesis, disrupting the cell function, ultimately leading to the cell death. The toxin also incites an inflammatory response, in the net effect being to establish prothrombotic state within microvasculature. The concentration of cell surface GB3 is particularly high in the kidney, not only on the endothelium but also on the podocytes and tubular epithelium. This may explain the susceptibility of the kidney to injury, but other factors such as high renal blood flow may also contribute. GB3 is also found in other tissues, including central nervous system, that are affected by the HUs. Now about diagnosis and management. Fecal culture should be performed in all patients with thrombotic microangiopathy, irrespective that there is history. Erythema may have settled by the time of presentation, but bacteria can still be isolated. Therefore, stool and rectal swab should be sent. PCR can be performed on this sample to detect the presence of Shiga toxin G. Positive serology for antibodies against Shiga producing E. coli serotype. It's supportive of diagnosis of Shiga toxin enterocolitis HUS, although it is not routinely used. Currently, there is no evidence that treatment other than supportive care, including dialysis and ventilator support, is required and improve the outcome of patient with Shiga-like toxin HUS. Plasma-based therapy is no longer recommended for the treatment of Shiga-like toxin enterocolitis HUS and may in fact be harmful. The role of antibiotic is controversial and their use has traditionally been avoided because of concern that antibiotic treatment leads to more Shiga toxin release, increasing the likelihood and severity of Shiga toxin enterocolitis HS. The effect of antibiotic appear to be both antibiotic and E. coli strain dependent. The beta-lactam and the trimethoprim sulfamethoxazole have been reported to increase the risk of developing HUS. Although fluoroquinolone increase the toxin production, they do not appear to worsen the disease. Some antibiotics such as macrolides, phosphomycin reduce the toxin synthesis and may reduce the risk of HUS. When antibiotics are required, they can be used, but the choice of antibiotic should be guided by their potential effect on toxin release. In contrast, antibiotic use in patients with HOS due to Shigella appear to be safe. Trials of toxin binding resin have failed to show a benefit. A role of complement in the pathogenesis and therefore rationale for anti-complement therapy has been developed. In patients with the Shiga-like toxin HOS, there is evidence of complement activation and C3 levels can be low. In addition, there may be some patients with Shiga-like toxin HOS who have defect in complement regulation, and this combination is associated with the poor prognosis. These observations have led to use of eculizumab, a humanized monoclonal antibody raised against complement protein C5 in patients with Shiga-like toxin HOS. There have been reports of patients with Shiga-like toxin HOS, particularly in the presence of severe disease, responding to eculizumab. Now, pneumococcal HOS. This normally affects the children with severe pneumococcal infection, for example, pneumonia or empyema, where it complicates approximately 0.5% of cases. The exact mechanism of TMA is unknown, but the production of the neuraminidase by pneumococci appear to be important, although other mechanisms have been proposed. Neuraminidase strips celiac acid from the cell surface glycoprotein, exposing the cryptic Thomson Friedreich's antigen, which is recognized by naturally occurring IgM antibody. This leads to active platelet and endothelium, which may be responsible for thrombotic microangiopathy. Also explain why these patients have positive Crohn's test. Pneumococcal pneumonia is the most common preceding infection, but the thrombotic microangiopathy can develop in association with meningitis, empyema, sinusitis, and otitis media. Because of the underlying disease, children are often unwell, with 75% requiring dialysis, and extrarenal manifestations occur frequently. The mortality rate is higher with the Shiga-like toxin HS. The treatment is supportive and the role of plasma exchange is uncertain. Although response to eculizumab have been reported and evidence for its use is limited. Now, HOS occurring in the with other infection. Shiga toxin associated diarrheal disease like E. coli and Shiga dysentery type 1. Non-Shiga toxin associated diarrheal disease like norovirus, Clostridium difficile, Campylobacter upsilonus, respiratory tract infection like Streptococcus pneumoniae, H. influenza, and Bordetella pertussis. Other bacterial infections like Fusobacterium necrophorum, viral infections like HIV, cytomegalovirus, Epstein-Barr virus, varicella zoster, influenza, hepatitis A, C, Coxsackie B, dengue virus, human herpes virus 6, parvovirus B19, and parasitic infection Plasmodium falciparum. Now about atypical HOS. Atypical HOS is mainly complement mediated and inherited or acquired defect in the control of complement activation can now be found in approximately 60% of cases. In addition, a role of complement activation has been suggested when thrombotic microangiopathy occurs in specific clinical scenario. Although the contribution of complement activation in this situation is less clear. A typical HOS occurring in the presence of defined defect in the complement regulation as a distinct entity and secondary TMA separately. Clinical features. Complement-mediated atypical HOS predominantly affect kidney, but as with other form of HOS, extrarenal manifestations are also seen in approximately 20% of cases, neurological disease being the most. Older reports suggest the poor prognosis with up to 50 to 60% of patients dying and the progressing to end-stage renal disease within 1 year of presentation. This is influenced by underlying genetic factor as a patient carrying mutation in the complement factor H have a worse prognosis and those with the mutation in the CD46 have a milder disease. Now about diagnosis and treatment. Diagnosis is based on the exclusion of other possible cause of thrombotic microangiopathy, particularly TTP and Shiga-like toxin infection and E. coli infection. C3 can be low in this patient group, but normal C3 level does not exclude complement-mediated atypical HS. Genetic screening assessment for the presence of autoantibodies and neutrophil surface CD46 level should be performed in all patients. However, these results, particularly genetic analysis, are not immediately available and therefore do not guide initial diagnosis and early treatment choices. Plasma exchange was the standard treatment and is still first line until TTP have been excluded. Once TTP have been excluded, eculizumab is currently the optimal treatment. But because of its high price, this is not available in all countries and plasma exchange is still used. Eculizumab is highly effective treatment for complement-mediated atypical HOS and establishing remission in more than 85% of cases with significant improvement in the renal outcome. The use of complement inhibition to induce remission and intermittently treat relapse may be the future strategy to manage disease that would reduce the treatment burden, cost, infection risk associated with continuous treatment. As the liver is the main site of complement protein synthesis, liver transplantation has been proposed as cure for genetic cause of complement-mediated atypical HOS, particularly in those patients who also require kidney transplant. With availability of the eculizumab, this option is used less. For patients with complement-mediated atypical HOS who develop end-stage renal disease, there is high risk of recurrent disease following transplantation, and this is true for all genetic and acquired cause of atypical HOS, with exception of patients who have mutation in CD46, which because it expressed on renal transplant endothelium has normal function in the transplant kidney. Disease can recur in patients in whom no defect in complement regulation is found, although the risk is lower. Recurrence usually occur early and is associated with high risk of graft loss. With the availability of eculizumab, patient can now be successfully transplanted and with option to use eculizumab to treat disease recurrence and prophylactically to prevent the recurrence. Now the atypical HOS in clinical scenario. The pregnancy associated TM. There are a number of causes of thrombotic microangiopathy either during pregnancy or in the postpartum period, including preeclampsia, HELP syndrome, TTP, and atypical HOS. Differentiating among these can be difficult and is reviewed elsewhere. Approximately 20% of cases of atypical HOS occur in association with pregnancy, and these most commonly occur in the postpartum period. These observations have led to the use eculizumab in the pregnancy-associated HOS with report of good outcome, although no trial data are available. TMA associated with severe hypertension. Severe hypertension causing TMA and atypical HOS due to inherited defect in the complement regulation can present with identical clinical feature. Pre-existing hypertension, particularly poorly controlled, other features of hypertensive end organ damage make secondary TMA more likely. However, if there is no improvement in lab parameters with control of blood pressure, treatment with eculizumab should be considered at least until genetic analysis is available. Now, the drug-related TMA. The development of thrombotic microangiopathy have been reported in associated with the use of range of drugs, including those used in the treatment of cancer, immunomodulator, and antiplatelet drugs. For some drugs, this appear to be direct effect on endothelium, as is the case of interferon beta and bevacizumab, while in the cases of quinine, TMA is due to development of autoantibodies against platelet glycoprotein. TMA is induced by clopidogrel and the ticlopidin leads to the production of antibodies against Adams 13 and TTP-like disease that respond to plasma exchange. Now, the drugs implicated in the development of thrombotic microangiopathy. Chemotherapy drugs like cisplatin, mitomycin, gemcitabine, vincristine, oxaliplatin, and the pentostatin. Antiplatelet drugs like clopidogrel and the ticopidin. Vascular endothelial growth factor inhibitor, bevacizumab, uh, ramucirumab, afibirexapt, immunosuppression like cyclosporin, tacrolimus, sirolimus, everolimus, alemtuzumab, and the muromorb CD3. Interferons like interferon alpha, interferon beta. Tyrosine kinase inhibitors, sunitinib, sorafenib, and then cediranib. Antibiotic like penicillin, ciprofloxacin, and the sulfasalazine. Illicit drugs like cocaine, heroin, and the ecstasy. Miscellaneous drugs like oral contraceptive pills and the Q-tip. Malignancy associated TMA. TMA can occur in wide range of malignancy, including stomach, breast, bowel cancer, and hematological malignancy. The exact mechanism of disease is unknown, but the microvascular metastasis can initiate TMA. In some patients, it may be difficult to differentiate between TMA caused by malignancy or due to chemotherapy used in its treatment. Now, post-bone marrow transplant TMA. The development of the TMA has been reported in 10 to 40% of patients following allogenic bone marrow transplantation. There are several factors that could contribute to this, including graft versus host response, calcineurin inhibitor, chemotherapy, and infection. Defect in the complement regulation have also been reported, and there is evidence for complement activation in some cases. This observation has led to the use of eclosimab in this situation, although evidence that this should be part in the management of this condition is still lacking. Now, the TMA following solid organ. A TMA can occur after any solid organ transplant, most frequently kidney transplantation, and is due to number of factors, including calcineurin inhibitor toxicity, ischemia, reperfusion injury, autoantibody mediated rejection, and infection. Complement mutation have been reported in up to 30% from one series, possibly due to recurrence of previously undiagnosed atypical HS. Complement inhibition should be considered particularly if there is uncertainty about primary diagnosis or TME does not resolve with measures such as calcineurin inhibitor withdrawal. TMA occurring in patients with autoimmune disease. The presence of TMA has been reported and associated with the range of primary glomerular disease. For example, IgA nephropathy, ANCA-associated vasculitis, and focal segmental glomerulosclerosis. Patient with the C3 glomerulopathy, a disease also characterized by complement dysregulation, may also develop TMA. The TMA can also develop in the lupus nephritis and in patients with antiphospholipid syndrome, particularly catastrophic antiphospholipid syndrome. Complement is activated in both of these diseases, and a role for eclosimab has been reported. But evidence for the clinical trial is not available. TMA can also be seen in patients with scleroderma renal crisis. Thank you, guys.